Hi, welcome back to our April edition of Sisterhood in Surgery. Today we are weighing in on the new obesity medications on the market. It's been a hot topic. My co-host Paul Shaw, we have two great guests here. Why is this important? Well, I mean, jokingly, Jimmy Kimmel announced at the Oscars, why is Ozempic right for me, right? But because apparently all the celebrities are taking it and it's this hot new drug. But, honestly, the stats are pretty depressing. In the U.S., about 41% of patients are obese, and what does that lead to? That leads to heart disease, stroke, type 2 diabetes, and certain types of cancers. And these are some leading causes of preventable premature death. We definitely see that in the vascular world. Lots of end-stage diabetes, chronic kidney disease, hypertension. All this leads to terrible vascular problems, and it costs the U.S. about $173 billion to treat obesity. This was stats from 2019, and so we figured this was a great topic, not only for Sisterhood and surgery, but for really anybody that is more interested in this, and just to get the pros and cons and see what it's all about. So I'll start off with my first guest, Dr. Shauna Levy, who's also my friend, and we were residents together. She's in New Orleans, where I'm from. She's an assistant professor of surgery at Tulane University Medical Center. She started there in 2017. She's double board certified in general surgery and obesity medicine. She is fellowship trained in minimally invasive surgery with an emphasis on foregut and bariatric surgery. And she's also the medical director of Tulane's Bariatric and Weight Loss Center. She's been very interested in fitness, weight loss, and nutrition. She's passionate about helping her patients treat the disease of obesity, and she specializes in anti-obesity medications as well as surgical weight loss treatments. She works with each patient to help them achieve long-term weight loss. She has been improving access to care for obesity treatments and educating the public on obesity treatment options. She is recently famous, featured in many news outlets, such as The Hill Magazine, BBC World News, NBC News Online, The Daily Mail, and Food We Need to Talk podcasts, America Dissected podcasts, and soon The Atlantic. In her personal life, her favorite role is a mom of two young girls, and they enjoy spending time exploring Louisiana. Welcome, Dr. Levy.
Thank you so much for having me. So happy to be here.
And it's my pleasure to introduce our second guest, Dr. Archana Sadhu, who is an assistant clinical professor at the Weill Cornell Medical College and adjunct assistant professor at Texas A&M Health Sciences. Her medical career began with a Doctor of Medicine from the David Geffen School of Medicine at UCLA, where she finished with honors, and also completed her internal medical training as well as fellowship in endocrinology, diabetes, and hypertension. Since 2010, she has held positions of System Director of the Diabetes Program and Director of Transplant Endocrinology at the Houston Methodist in Texas. She leads this large 8-hospital system in evidence-based clinical practices, clinical research, and education to ensure comprehensive, high-quality, and cost-efficient care of persons with diabetes. Additionally, Dr. Sadhu has unique expertise in a complex group of patients who undergo organ transplantation, and in particular, pancreas transplantation, and serves as the medical director of the pancreas transplantation at the J.C. Walter Transplant Center at Houston Methodist Hospital. She is also passionate about educating all healthcare professionals that impact the care of persons with diabetes, and has been an invited lecturer at national and international conferences. She's also received recognition for her expertise and has been awarded the Alan J. Garber Diabetes Educational Lectureship for the prevention and management of the complications of diabetes by the American Association of Clinical Endocrinology. Additionally, I understand that she's also well sought after for public appearances and also through the newspaper. She's been in the Chronicle, local Fox News, and tomorrow will be on the local news, so check her out tomorrow. Thanks for joining us.
Thank you for being here. And we are so blessed to have two such experience and experts in this field. Remember, this is a live show, so you can send in your questions. Join by web, go to pollev.com, enter DeBakey, or join by text. Text DeBakey to 37607, and we will get your questions answered. So what are the new weight loss drugs and the science behind them? Dr. Sadhu, do you want to start?
Absolutely.
Yeah.
Thank you for having me here.
Yes.
It's going to be a wonderful discussion and so much to say about it. So this new class of drugs is phenomenal. It is part of what we call the incretin system, which basically means hormonal hormones that are related to gut and everything related to food, really. So there is the first class of the system was the GLP-1 receptor agonist, and this is the Wegovy and Ozempic brand names that we often refer to. And then the newest class is a dual incretin hormone, which is both GLP-1 and GIP together, and this is the newest Mounjaro or tirzepatide. So this is a whole new class of drugs, and it was initially, the whole class was studied for patients with type 2 diabetes and found to be very effective in reducing glucose. But along with it, we also found that it was very effective in reducing weight. So each of these companies, manufacturers, have then done subsequent studies for just weight loss alone without the diagnosis of type 2 and found consistent results with weight loss. And so now semaglutide, which is either Ozempic or Wegovy, can be used for type 2 diabetes as well as overweight with a chronic condition related to weight loss, obesity, or obesity by BMI criteria. And tirzepatide at the moment is indicated for type 2 diabetes, but soon we'll get the indication for the same obesity or overweight with a chronic condition.
And it's all over the news. Shauna, any thoughts on the misconceptions by news media?
Oh, well, there's a lot of thoughts there.
I know, that's why I brought it up.
I mean,
start with one.
It depends on specifically what you want to get into, but I think one of the areas that's a little bit confusing is this idea that's been perpetuated that the shortage of Ozempic, which, like was mentioned, is FDA indicated for the purposes of diabetes, is on shortage because people are, sort of stealing it for the purposes or misusing it for the purposes of obesity. And what we have to remember is about 80% of people with diabetes also have the disease of obesity. So there's tremendous overlap. That's the first thing. And, the main reason why there's a shortage for Ozempic is because more people need to use it than supply exists at the current moment. Of course, there are people that are using it off-label, or there are people that might be using it for the wrong reasons, but the majority of instances of this medication are used for, the reasons that they were indicated. And we have to also remember that semaglutide is FDA approved for the purposes of weight. So when we talk about people with the disease of obesity using semaglutide, it is a true indication, and there's nothing wrong with that. So again, when the media, sort of blames people with the disease of obesity for causing a shortage, that's not appropriate. And when we think about obesity, there's very few medications that work really well. One really that works very well, Wegovy, and you could argue that Saxenda also works well. But when it comes to diabetes, there's a lot of medications. So it's just really not a fair comparison, and it really drives me nuts.
So how do you utilize these medications as a transition to having surgery? I mean, do you use them in your practice? Do you initiate the medications as a bridge to surgery? Is that an algorithm?
Yeah, I mean, much like chemotherapy when it comes to oncologic patients, sometimes chemotherapy is used before somebody has surgery for cancer, and sometimes it's used after, and sometimes it's used in conjunction. It's very similar with treating the disease of obesity. Sometimes we use weight loss medications to help. Sometimes people are not interested in weight loss surgery, and they want to start with weight loss medications and see what they can do with it. And sometimes they find that it doesn't give them enough weight loss, and so they want to transition to weight loss surgery. And sometimes we use it to help, bring a BMI down to make surgery a safer possibility. And sometimes people, don't get enough weight loss with surgery and want to use like weight loss medications in conjunction afterwards. The thing that's, I think, important to remind patients is that they think, why did I fail to sleep? Or why did I fail to bypass? Why did I not lose enough weight? But the truth is, the surgery probably just wasn't the right treatment for them, or didn't offer enough treatment for them. And using weight loss medications afterwards is not a sign of failure. It's not a sign that they did something wrong. It's just that their disease could not be treated adequately enough with surgery alone. And we really need to have a mindset shift to understand that these are just treatments for disease and not a reflection of not doing enough.
So would you recommend using a medication to get to a certain weight that would then put a patient into a better or lower risk category in your perspective? I mean, would you say if we get you down to this part or this weight, now you'll have less complications based on the data?
I don't think we have that data, but it's something that we are looking into at our institution, and I'm sure a lot of other institutions, of truly understanding how taking GLP-1 receptor agonists before and after surgery affect outcome. Because I think, an unanswered question is, for instance, with the sleep, we know that it doesn't impact GLP-1 to the same degree that a gastric bypass is. So if somebody has weight loss beforehand with a GLP-1 receptor agonist, and then they have a sleep gastrectomy which affects other hormonal pathways, will they have rebound weight gain and then net neutral weight loss? Not to get overly complicated, but I think there's a lot that we still need to understand about these great medications with weight loss surgery.
Dr. Satter, you were about to say something. Okay.
Well, I was actually just listening, but thinking about when to choose a patient for GLP-1 or any anti-obesity medication versus surgery. And we have these conversations with our patients all the time in the office, so we're kind of initiating the thought process a lot of the time. Obviously, as I mentioned, these drugs are phenomenal for glucose reduction and improvement in diabetes. They also have other indications for cardiovascular protection. They also help with chronic kidney disease. So when you have this whole syndrome together along with the weight, these drugs are usually our first go-to treatment plan. And when we don't get enough of the weight loss and we're still struggling with the other diseases related to the weight, like the diabetes, etc., we can offer also bariatric surgery. But even if we do offer bariatric surgery, and even if we get the desired weight loss from surgery, these drugs may stay on as indications for all these other benefits most of the time as well.
And we were talking before this about your comments, because you do get asked to speak about the shortage and how that relates to the international supply. So can you comment on that?
Well, this is just the information that I've been given from multiple sources, and it makes sense that this is what the picture was Wegovy came FDA approved and had a pretty big demand, obviously. However, there was two issues that happened. The demand was much more international than U.S. because here coverage, as we mentioned already, for these drugs deemed as cosmetic purposes is really hard to get, and they're very expensive for patients to pay out of pocket. So one, a lot of the supply was going internationally. And I believe that there was some manufacturing issues with the drug in some of their plants, and that also hindered. So decreased supply with increased demand created a significant shortage of Wegovy. So then Ozempic, which had been on the market much longer than Wegovy, became an alternate off-label indication for weight loss, even when patients did not have diabetes. So it was a domino effect, really. One led to another, and both drugs became extremely unavailable in the U.S. at least.
And why are they so expensive? And both of y'all can comment. I mean, you know, is it the marketing? Is it the actual making the drug itself? I mean, why is it, and is that other countries, are they paying those prices? The government paying those prices?
This is a very big topic and doesn't only apply to these drugs, but many drugs.
Right. Yes. Yeah.
So you can go down the line on each step of the process between manufacturing. Yeah, these are peptides. And that's obviously going to be much more labor intensive in manufacturing them, and the FDA regulates that kind of manufacturing very closely, and it's costly in the U.S. So that's one thing. Any injectable is going to be much more expensive in the manufacturing. Then you go all the way down the line to marketing and recouping R&D costs, which I think are not as big as some pharma claim to be the reason for their drug pricing. But marketing is a big one. And now they're doing a lot of direct-to-consumer marketing, so that part of the budget has really expanded for these companies. And then you have the negotiation of the pricing with the PBMs, the pharmacy benefit managers, who are the middlemen that go from the actual pharma company to the insurance company to the patient, that also contribute to the inflation. And so how is this different than the international market? Well, you know, those are usually universal healthcare, and they don't have all of these steps along the way. And yes, I think pharmaceutical companies do price them a lot less internationally. The same drug will be a fraction of the cost in an international country than the U.S. And you know, insulin, for instance, insulin has been around, just celebrated 2 years ago its 100th anniversary. It is one of the most expensive diabetes drugs still. I mean, it should be cheap. And it took a national policy change for finally, discovered 101 years ago, to this year being affordable for patients at a set cost of $35 a month. So you can imagine how slow we are in the U.S. in addressing drug costs.
Wow.
Yeah. I think, if I might add, one thing that we can't forget is the role that obesity discrimination and bias plays into this conversation. It's my understanding that about 99% of insurance companies cover Ozempic, which is a medication, you know, of course, as we mentioned, with the indication for diabetes. Wegovy, which is the identical molecule, they're both semaglutide, is covered by about 20% of private employers. It's not covered by Medicare. It's only covered by a fraction of Medicaid and a fraction of Affordable Care Act states, coverage plans. And, you know, when you look at the identical molecule and same approximate cost, the differential of insurance coverage, how can it not be obesity discrimination? I find it hard-pressed to believe that this is not a huge factor when we think about coverage in these circumstances. And so then when we think about why drug is so expensive, we only have to think about it because insurance is really not paying for it. Because if insurance coverage were better, I don't think people would be discussing the cost as much as they are.
Absolutely. I mean, how much does it cost without insurance?
So these drugs run anywhere between $900 to $1,300 a month. For cash pay. So they really are prohibitive.
Yeah, I mean, unless you're rich, you can't. I mean, that's a lot of money for each month.
That's a big chunk of someone's budget for sure.
Yeah, and you mentioned that this is true for a lot of other medications, like antihypertensive medications, and like some of the fancier insulins are very expensive, but they're covered. I mean, a lot of times they're covered, and so.
But coverage, true, but coverage does not always also, even for the diabetes indications, coverage does not equate affordability. They're usually much higher tier.
Yeah.
And a patient still on a limited income has to decide, do I take $4 a month metformin or this Ozempic fancy new drug that will be maybe $200, not $1,000, but $200 a month.
Right.
It's still not affordable for them. And it's not, just these medicines. It's a lot of medications that fall under this category. But certainly I understand what you're saying about the obesity discrimination. It's similar to type 2 discrimination. Well, you did this to yourself, so it's on you. There is an underlying message that, this is not critical for a life, although insulin is, and that, we will make this less accessible.
Yeah, and so you can see the socioeconomic implications of these drugs.
Of course.
Especially in the U.S., where, there's...
So it self-selects just by being
right.
so expensive. It self-selects, and social determinants of health are, unfortunately, a great role in access to this drug.
Well, and so the short-term, long-term, I mean, y'all both talked about having to, take this medication for life. And so what are some of the complaints that y'all's patients say about these drugs?
It's interesting. Well, again, it depends on the indication. So if it's just obesity, a lot of them will come and say, is it time for me to get off? I've gotten a significant amount of weight off from these drugs. And that's when we have the conversation about all the variables that go into weight. So it's great that you lost 30 pounds or you're at your weight goal now, and now you want to be off the drug, whether it be for cost, whether it be for concern for long-term side effects, because we really don't have decades of data on this drug class yet. Whatever, or there's a shortage and now I got to get off the drug. I'm really afraid. Now I'm forced to be off the drug and I'm afraid I'm going to gain all this weight back. So this is a time to really have that conversation about lifestyle changes. And I did a recent discussion about this, and how do you advise a patient who has to come off the drug to manage their weight? And I think there's really great tools now that help people understand how many calories they're consuming, and that's really important. So as you know, the incretin class, this GLP-1 effect, is not only in the gut, actually, it goes to the brain and directly suppresses the appetite center, and that's one of its main mechanisms for weight loss. So when you lose that, your appetite rages back, really, and so then you have to really force yourself to follow the same caloric intake that you were using on the drug. And so as we've been trying to taper patients off the drug who want to be off the drug or have to be off the drug, we start with, well, look at how many calories you're consuming because of your appetite suppression from the drug, and maintain that caloric intake when you can't take the drug. And then physical activity. I cannot tell you how important that is to substitute when you have to for this drug. Doing that regular exercise regimen, 30 minutes a day, 150 minutes a week, moderate cardio with strengthening, and it really does help maintain your metabolic rate. And that's really what you're trying to do. When you come off the drug, your basal metabolic rate immediately goes up, and you want to be able to match that basal metabolic rate with lower calories and increased energy expenditure to maintain the weight that you had.
And so with diabetes and these medications, if the patients have lost the weight and controlled their glucose, once they get off of it, if they're able to, have you seen patients successfully transition to glucose control, which is diet and exercise? Okay, that's great.
Well, diet and exercise is probably a little more rare, but it can happen. It can certainly happen. But because we're afraid of losing that glucose control, we'll substitute with some of our older, metformin might be enough now. Whereas before, with 30 extra pounds, metformin wasn't enough. So we may be able to de-escalate their diabetes therapies from the weight loss due to the GLP-1 class.
Well, that's great news. Yeah.
But even
Sorry.
Go ahead.
No, go ahead.
I was just going to say that even the benefit of improving their mobility, a lot of the patients I see in the office who are overweight, they have terrible knees, their joints, and they say, I can't get my knee replaced because I still weigh too much. I have to lose weight to get my knees done, but I can't exercise because my knee hurts. So I can't lose weight.
It's a rock and a hard place. Yeah.
Cycle.
It's awful for them, and
Yeah.
these drugs are perfect because they will get them to, actually I have a patient in exactly that position, a young patient actually, and with a congenital issue that caused the hip, actually it was a hip issue, and she needed surgery, but the weight was so high that the surgery wouldn't be as successful. And so we bridged with this drug class, and with significant weight loss, she was able to get the surgery. Now she can be more mobile and maintain the weight with or without the drug, depending on what they choose to do.
Shauna?
I was just going to say that we know from step 4 of the clinical trial on Wegovy that when they stop the medication, most likely everyone is going to gain their weight back over time. You know, I'm speaking from people with the disease of obesity. They did a crossover halfway through the trial, and half the patients were taken off Wegovy and half of them continued on Wegovy. The people who continued on Wegovy continued to lose weight, and the people who were stopped on Wegovy by the same endpoint had not only regained all their weight, had gained back probably about 8 pounds. So
You're saying 8 pounds more than their base?
Than their starting weight.
The baseline weight.
Okay, so gaining more weight. Okay.
Yes, and that's pretty typical with the disease of obesity is that when you lose weight, our body drives us to gain the weight back and usually gain back more weight. And that's because of our hypothalamic set point. Which is our body's way of saying, you know, where we want our weight to be. And this is something that's, you know, prehistoric from our hunter and gatherer days, that our body is meant to be in this place where we have to find our next food. And so it's a survival advantage for our body to hold on to calories. But now that we're in a place where, you know, calories are plentiful and they're not hard to find. Our body really holds on to calories in the same way, and it leads us to gain weight. And, you know, I've been asked before, is this not a man-made solution to a man-made problem? Of course it is, but it's going to be very difficult for us to change our environment to go back to where we were. So we kind of have to deal with our weight in our current situation, and these medications help us do that. And so when somebody talks about wanting to come off medication, I usually encourage them from the very beginning and advise them that this is a lifetime medication. I guess some people have to come off of it, you know, for cost or for whatever reason, but they really most likely are going to gain back weight. And it's not because that they're failing, or it's not because they're not trying, it's not because they're not disciplined. It's simply because of the way the disease of obesity occurs.
There's many hormones at play that rebound. Ghrelin, for instance, will rebound once you come off these drugs and just drive that appetite back up and lower the metabolic rates. And it really is an uphill battle when you come off the drug. And you're absolutely right, obesity is a chronic condition. Just like if you had hypertension, you wouldn't encourage someone to come off the drug once the blood pressure is controlled.
Right.
But unlike those other conditions which have been you know, well established with multiple types of therapy, obesity, we have this drug class that's just cost prohibitive right now. And so for many reasons, patients need a plan sometimes on how to transition off the drug, unfortunately. But yes, all of these things can get worse. Your diabetes can get back if you are taking it when you gain enough weight, or you could continue to develop beta cell dysfunction and go into diabetes. And again, you know, if you have cardiovascular conditions that are related to the weight, these drugs have benefits there, and if you come off, you're going to lose that benefit as well. So a lot of reasons to maintain the therapy, but we have to provide them access to the therapy. And when they don't have access to the therapy, we still have to give them some guidance on what to do about weight. My big point about all of this, and you're absolutely right, you know, there's a lot of stigma associated with this, and there's a lot of variables, not just the patient's will, which often is cited as the main reason, that go into obesity as a society. And I think the most valuable intervention is going to be education with our kids and making sure that they don't become adults with obesity that then just begets obesity in the next generations to follow. And it's been such a problem with pediatric obesity. Now about 20% of kids from age 2 to 19, 20%
That's a lot. Wow.
have overweight or obesity. And so all we're doing is pushing the problem down the line. And it's such a problem that these drugs have now have indications to use in pediatrics. And the American Academy of Pediatrics just released their guidelines this year in January saying we need to be more aggressive with everything, but also use pharmacotherapy when everything else is failing. Because we just can't afford to have all of these kids grow to become adults with obesity and all the medical conditions related to that. It's going to be a disaster. So we need to attack this problem in multiple different directions.
And so, are those insurances paying for the
Probably
pediatric?
not.
Yeah, I was going to say. I mean,
but when evidence is so strong, and it comes into the guidelines, this is what changes coverage eventually.
Eventually,
not immediately, of course. And then you have to have supply of the drug as well, which has been our most immediate problem.
So are there political activists working on this? I know in vascular surgery we make guidelines and clinical recommendations. We take the data, and then in fact, in June we're going to march on Washington to promote some vascular surgery things that we need to address. But what's happening it seems like you just have so many reasons.
I know. So, I mean, like how could they not say no? That's what I don't understand. But
well, like I said, it took over 100 years to get insulin affordable. So you can imagine how slow these wheels turn. But the American Obesity Society, 3 different endocrinology societies, pediatrics, American Family of Physicians, are all saying the same thing. These drugs are needed. These drugs should be accessible universally, not just to those insured, but address the social determinants of health as well for the future health of this country.
The Obesity Action Coalition is one of our main obesity societies that's advocating for rights for people with the disease of obesity, but there's also the Stop Obesity Alliance that's advocating for, of course, our obesity surgical societies are also advocating for the same rights.
So it sounds like you have many lobbyists, but is it the insurance company lobby? I hate to.
Wow.
Yeah, yes. I'm about to get removed from the world, but I'm just
what we need to remember about insurance, and I think this is a point of confusion for a lot of people, that unless you're talking about government-funded insurance, we're talking about employer-based insurance. Right. And so the employers decide which plans they want to include, and obesity is often an opt-in or opt-out situation, however you want to, whatever language you want to use. So employers have to decide that they want to cover obesity, as opposed to other things that are considered essential health benefits that they don't have to decide, include or not include. Obesity is often left out of that. And so you have to actively decide that you want to cover obesity. Do you know if your institution covers obesity?
We do, actually. Yes.
Oh, that's nice.
That's wonderful.
Lucky enough.
Yeah.
Thank goodness.
Our employer-based insurance does cover these drugs. Again, it may not be affordable for the employee depending on their total salary and the copay for the drug as it relates to their budget.
But at least it's covered, yeah. The reason why I say the whole lobbying, because that's part of when we talk about vascular surgery and getting rid of the Medicare cuts, and because there's only like one pot, right? And so it's like, who gets part of the pot? There's no like extra. So if you're taking away from one specialty, it's because you're giving it away to another specialty. And we are just such a small group that even though we're lobbying in June, we don't compared to, you know, like the cardiology, like American College of Cardiology. There's just, you know, orthopedic. I mean, they're massive, you know, and so, and really, I mean, there's just, like, we could do a whole show on this, but, like, you know, so we're really under, you know, the American College of, you know, to be bigger and to fight for, you know, to have more oomph in our fight. But I mean, that's just what I wonder. Sometimes, you know, like as physicians, you know, we have a medical organization like the AMA, but it's like we're too busy taking care of patients to go lobby for you know, for funding for you know, for no Medicare cuts, for benefits for physicians. So that's why I asked that question.
It does take a team of approach to get this done, and it can be done. It's been done. I keep coming back to insulin. It's been done.
Yeah,
it's just
but it took 100. It took 100 years. You know,
right?
Like,
and the patent for insulin by the founders was sold to the institution for $1.
Wow.
So that it can be accessible for everyone.
Wow.
And yet, the pharmaceutical industries ran away with it for over 100 years. So
I've been working closely with lobbyists, and you know, some of the goals with obesity are to really get, like you mentioned before, to get government to change policy. As I mentioned before, TROA, the Treat Reduce Obesity Act. You know, we've been working on that since 2013, but also the Affordable Care Act, which I'm sure you're familiar with. You know, pushed through with Obama to get coverage for people. Has an exclusion on obesity, and it's not considered an essential health benefit. So we've been trying to get that changed as well, which would be through the Health and Human Services. And so that would be very beneficial for millions and millions of people if we could get that language changed so it becomes an essential health benefit. Because really, if Medicare starts covering anti-obesity medications, Affordable Care Act, I mean, employers are going to really have no choice but to cover it. So that really needs to be where change starts.
We have a question.
What about social media, though? The social media. I mean, 100 years ago,
Oh, God.
you didn't have social media, right?
Yeah.
But I mean,
well,
you could say one thing and make a blog. You were on a webinar discussing this, right? I mean, it's a different era.
Yeah, and I agree with you. And I'm on TikTok, so I'm trying to spread the word as well. There's a bunch of us out there that are trying to advocate and, you know, communicate. And patients are saying the same thing, like, look how much my life has changed. And, you know, we haven't even gotten it to compounded semaglutide, but there's a lot of conversation about that on social media as well. You know, as Dr. Lay mentioned, you know, I wrote an op-ed for the Hill magazine, which is a Capitol Hill magazine, trying to talk about the same issue. So we're trying to spread the word as much as we can, but it's just hard because not everybody's willing to listen. There's so much shame when it comes to the disease of obesity. So a lot of people feel like, if I had only worked a little bit harder, if only I'd tried a little bit harder, maybe I could have done a better job. But no, it's a disease. It's so much more than willpower. And you know, that's also part of the message, because I think if people really understood that this is in fact a disease, it would be a no-brainer that, of course, we treat other diseases, we treat disease with medication and surgery.
There's a question from the audience. Is it possible that insurance companies will see covering these drugs as profitable in the long run by preventing complications from obesity?
Well, that's the hope, isn't it? But to convince them, or as you mentioned, it does start with government payers, Medicare. Once Medicare is convinced and does something, the commercials follow. But we need cost-effective studies to show them the numbers. It makes intuitive sense. Obviously, you have a 30-year-old with obesity, and you bring their BMI down from 35 to 25, they're less likely to get type 2 diabetes and hypertension, dyslipidemia, cardiovascular disease, joint disease, you name it.
End-stage renal
so
disease.
Many things. But then you have to do this
this
study in the very, very long term, and I don't think anyone is funded to be able to do that. So we need to do, we need to do our due diligence and show that our researchers needs to demonstrate the potential benefits, the economic benefits of this drug class, or weight loss alone even from this drug class. And that will hopefully drive the train a little faster, get everyone to understand. So I have a personal story about that. This was when Saxenda, liraglutide, was first approved for weight loss alone. And I had a patient, pre-diabetes, pre-hypertension, and BMI mid to late 30s. And so I prescribed the drug, and of course it came back denied. And so I did a peer-to-peer discussion. And I explained to this physician on the other side, representing the insurance company, this is where this lady's path is going. This patient's path is headed towards type 2 diabetes, headed towards hypertension, cardiovascular disease. If we can just get her weight down now, you are preventing all of this, and in the end, this saves you money. And I was successful in this one case. She said, I will give it for 6 months, and then we'll see. And then I think the patient did take it, did get some weight loss, but this wasn't the most effective weight loss drug, not like our semaglutide and tirzepatide these days. And then I lost her. Like she moved and I didn't get to follow up. And this is what I believe, and I've also read some literature about, is an insurance company really is only responsible for a patient, this is a commercial insurance company, for a few years. They tend to change jobs and change insurances.
Yeah.
So their financial statement is very limited. So if you tell them, I'm going to prevent, you give me $50,000 to treat this patient with a prevention medicine now, and I'm going to prevent diabetes and heart disease 20 years from now, they're like, well, that our financial statement doesn't go out that far.
Right. And probably in 20 years, that person's not going to be our problem anymore.
It's not going to be our problem.
Yeah.
They
18 months.
They are super smart. That's even less. I've read 3 years, but
so
they
18
change
months?
every couple of years. Like that.
Yeah, a lot of people change their jobs about every 18 months. I mean, not us, right? Like we usually stay a lot longer, but for other types of employees and employers, they look at about 18 months of coverage for somebody. And so there's a lot of concern about the upfront investment and having to pay for these medications. So that's, the issue we've had with bariatric surgery as well. We do have those cost analyses and we see those savings, and we know that there's prescription savings benefits starting at 3 months post bariatric surgery, and about by 18 months, bariatric surgery tends to pay for itself, especially when patients have diabetes. But insurance policies insurance covers worry more about the upfront, having to pay for all those surgeries, having to pay for medicines. And so it makes it hard for them to think about the long-term gains. But if there was universal coverage, everybody would win.
I never thought, I don't know why I didn't, but I never thought of the short term.
Do you know why you didn't?
Because
you don't have to deal with this in vascular surgery. It's covered.
Yeah,
these people need these emergency surgeries, and you don't have to worry about, does this patient have this type of insurance? What are their stipulations? Do they have to be, jumping through hoops for 6 months before they can have their vascular surgery? I mean, maybe I'm wrong because I'm also not a vascular surgeon, but these are the kind of things that we have to deal with obesity.
Yeah, well, I would say for us, literally probably a third of the time it's emergent. Palma, what would you say? It's through the ER, you're about to lose your leg or your mesenteric ischemia or you had a stroke. So really, the inpatient side, we don't even check because it doesn't matter. Even if they're not covered, they need the procedure. So.
Right. Well, some insurances are for claudication are requiring demonstration of smoking cessation for a period of time, but I think it's a minority, not the majority.
Yeah. Yeah. I think it's pervasive through all of U.S. healthcare that coverage is always going to limit access. I don't think that's specialty dependent or even some procedures, unless like you said, it's limb threatening or life threatening.
Right.
You're most likely, as a physician in the U.S., going to have to address these issues with any kinds of coverage for drugs or for procedures or testing.
Anticoagulation, the newer.
Imaging, new technology, all of it for sure requires some kind of jumping through the hoops.
A little bit, yes. So have y'all noticed any difference with these drugs between men and women since we are the Sisterhood in surgery?
non-gender bias, actually. They work in both genders.
Well, that's great news. Yeah, that's a plus.
Yeah.
Probably
I don't remember any
more
results. Oh, sorry, go ahead.
Oh, I was going to say probably for obesity indications, women are more actively seeking the treatment or any treatment at all than men, and I think that's just that is a gender difference there. But the drug effects are pretty equal.
Pretty good.
According to the clinical trials.
That's good to know. Shauna?
I think in general, men tend to lose weight easier than women. I think it goes down to like their electron transport chain or something is more efficient than women's. But either way, most obesity seeking patient or weight loss patients are women. We just know. But it's really hard when you have a husband and wife team that are trying to do the same thing, and that, you know, it's aggravating for the woman because the men tend to lose weight a lot faster.
Interesting.
Yep. Palma, we're about to run out. It's about to be 6. So any last questions or comments?
Time flies.
Yeah, I just think this has been incredibly informative, and I think I'm so excited that you guys are so passionate about this.
I know,
this.
really.
I never had to worry about this. It might just work out, and I really never been overweight. So, you know, I'm ignorant to a lot of this, but I really admire everything you're doing for these people and this disease process, because I think, who wants to live this way, worried that I can't eat one piece of pizza, or, you know, I have to eat 1,000 calories a day? I mean, how long can anybody endure that? It's just not fair. So I congratulate you and commend you for that.
Well, we have good tools now to manage obesity, and we're lucky to be practicing in this era, because I can tell you just a decade ago, our advice was really limited to lifestyle changes, and we all know how effective that is in the majority of cases. And some cases it works amazing. It really does. But, you know, our patients come back over and over, and we've not seen a budge in the weight, or they've been disappointed or even depressed over their weight. And now we really have effective tools to use for them. That's a very exciting time to practice. We just have to get over the hurdles we discussed today.
Shauna?
Yeah, I couldn't agree more. This is the most exciting time to treat obesity. I feel so lucky to be in this era to really help patients. I absolutely love what I do. I love being this, you know, advisor in this part of people's lives. But I just want to say, for anybody who's listening, this is not your fault. This is a disease, and there's help, and there's plenty of people. You know, I'm not in Houston, but there's plenty of people there. You can go to the American Board of Obesity Medicine website and look for a provider near you who's board certified in obesity medicine. And of course, the American Society of Metabolic and Bariatric Surgery, to look for somebody who might be able to help you with your weight loss journey through surgical interventions.
Well, we have an
Thank
amazing
you so much
weight
for
loss.
having me.
Yeah,
we have an amazing weight loss center here at the Methodist. So check
Great.
that out. And we do both, you know, medical management as well as surgical management. So. And then all the complications of obesity,
which we all see,
well.
yes. And then last question, I mean, can y'all comment on the newer drugs that are coming out, and what's exciting about that?
Wow, there are so many, and I think, again, it's really looking at different mechanisms of action. So it's a complex group of compounds. Not to, you know, rush them, but just to say that this is going to get even more exciting. It's going to be hard, I think, to demonstrate the same effectiveness as, for instance, tirzepatide or even semaglutide, but we will see, you know. And the thing is, we will have a variety of agents. So for patients who have contraindications to one class, we'll have other classes. For patients who have side effects to one class, we'll have other things to offer.
So many more options.
That's what it's about. It's, you know, the right treatment plan for the patient that suits all of their needs.
And competition.
Which is good for lowering cost.
Exactly.
Yeah. So.
Yeah.
Well, thank you so much. This was so informative. I've been looking forward to this topic for a long time. So I thank you for your time, your expertise, and just in general, what y'all are doing in life to help, you know, these patients.
pleasure to be here.
Yeah.
Thank you for the invitation.
Good
you.
night.
Thank you so much for having me.
Good night,
Have a
y'all.
good evening.
Have a good night.